Hi, everyone. Welcome to our Dr. Maskin Q&A. I just want to read a disclaimer before we get into it. Responses to today's question are as accurate and up to date as possible, but may nevertheless contain errors, omissions, or material that is out of date by the time you view this presentation. Dr. Maskin does not have any legal responsibility or liability for errors, omissions, out of date material, or view as applications of the medical information or advice contained in this presentation. The Q&A is being recorded and may be used by Dr. Maskin for promotional purposes. The information and suggestions contained in this presentation are not intended to replace the services of your physician or caregiver. Because each person and each medical situation is unique, you should consult your own physician to get answers to your personal questions, evaluate any symptoms you may have, and or receive suggestions on appropriate treatment. Dr. Stephen L. Maskin is the founder and owner of MGD Innovations Incorporated, which holds patents on instrumentation and methods for intraductal diagnosis and treatment of meibomian gland disease. I'd like to introduce myself. My name is Matt Orsina. Most of you know me if you have been a part of any of the Facebook pages or Reddit or any of the social media platforms that I frequent. I've been a dry eye sufferer since August of 2021, and I saw several doctors before I found Dr. Maskin in May of 2022. So the 9 months that I was suffering, I didn't know anything about dry eye disease. I just knew that I had it. And every single doctor I went to, I was offered a different treatment protocol and a different diagnosis. And I was becoming very frustrated with the industry as a whole. And of course, we all know that most of every doctor that we see has their own ideology on how to treat this disease. So in May of 2022, I had saw a YouTube video of Dr. Maskin and Dr. Kramer's, and it was something different than I have ever heard of before. And I had sent an email to Dr. Maskin and asked them kind of straight up, does this thing that you do work, or is this just another nonsense treatment? And he answered me right away and said, no, he thinks he can help me. And I booked my appointment and I live in New York, and I flew to Florida to see Dr. Maskin. And that's pretty much my story. Dr. Maskin is an ophthalmologist that specializes in solving the most difficult cases of dry eye, meibomian gland dysfunction, and ocular surface disorders. He has treated patients from across the globe who seek comprehensive care tailored to their specific needs at the Dry Eye Cornea Treatment Center in Tampa, Florida. He has published over 22 scientific papers on meibomian gland dysfunction, meibomian gland probing, and other eye disease-related topics. He is also the author of Your Dry Eye Mystery Solved, which is available on Amazon. At this time, I'd like to pass it over to him.
Well, thank you, Matt, and thank you all for being here. This is an important opportunity to review critical concepts in the foundation of management of dry eye and MGD that will restore comfort to eyes and restore your life. And so I thought to begin, it would be good to give some background about myself. Some of you that are joined us today are patients of mine. Some are not patients of mine. But just to share with each of you, I began my ophthalmology career as a resident in 1985 through 88, resident ophthalmology. That was followed by 3 years of fellowship. My 3 years of fellowship was broken down into two different fellowships, actually. One is ocular surface disease and dry eye. I spent 2 years in that fellowship where I actually grew meibomian glands in the laboratory. I would take lids from the rabbit and isolate the meibomian glands and culture out meibomian gland whole glands and individual ductal and acinar units, and then analyze the growth and differentiation of these cultures using different growth factors, which is fascinating looking back on it because here I am today essentially doing the same thing. Um, and it's amazing how the circle of life, as it were. But so that was 2 years of my fellowship, and then I did a third year fellowship, which is the traditional coin external disease. So I really can't, I'm coming at managing dry eye and dry eye and MGD from a very scientific perspective. And I think that affects how I analyze the management of dry eye and MGD and how I can successfully obtain comfort for my patients on a consistent basis. Uh, I think what we're going to do today is to begin with some basic some basic concepts. So I think we're going to turn it back over to Matt and start with some concepts. One of the first concepts is about the importance of comorbidities. Uh, Matt, you want to begin?
But yeah, let me just add. So when we put this together, Dr. Maskin and I were talking about doing this, and I am very active on patient advocacy, and I talk to a lot of people. A lot of people call me. I put my cell phone number out there on social media, and there's been a lot. I also want to add that who I am. I'm an electrical contractor in New York because a lot of people out there, when I start talking to them about different things about dry eye, say, well, he's just a paid promotional marketing person for Dr. Maskin. I have no ties to Dr. Maskin in any way other than just being his patient and friend. When I started seeing Dr. Maskin, him and I was suicidal, and he brought me back and gave me my life that I somewhat had prior. I do have a disease that I have to contend with on a daily, but I was unfunctional, suicidal, and I didn't want my life anymore. So when Dr. Maskin started treating me, we got a bond together because he was my savior. So I looked up to him tremendously. So when I preach to other people about Dr. Maskin, it tends to be one-sided, and people tend to think of me as a paid advocate of his. I assure you, I get nothing from him. I get treated from him, and that is all. And I pay my bill like everybody else does. I do this so it gives me some type of sense of why I have this disease and why God gave me this disease. And I could never make any sense out of it except to try to help other sufferers. And that's why I do it. So we first talked about this, what I see a lot on the social media sites is that people don't really understand the disease. And I tried to explain it to sufferers of the basics of the disease and how it works. And when Dr. Master and I first talked about this, I wanted the table of contents to be learning about comorbidities and learning about the disease as a whole, because a lot of people do not understand it. A lot of sufferers don't understand it. And I don't even think their doctors understand it. So I wanted to put it out to say, hey, Dr. Maskin, can you please explain this disease, how it works, how comorbidities affect each other, and what comorbidities are? And that's what I want to do. We will get to a lot of the questions. A lot of people have asked questions, and we're planning on doing not just one video. We plan on doing a series of these. We haven't decided whether it's going to be monthly, bi-monthly. It's up in the air right now on the response we get back from this one to tell us what we're going to do in the future. I have over probably 200 questions from different sufferers, and we will get to the questions eventually if we don't get to them tonight. But I want to discuss the fundamental concepts of dry eye and ask Dr. Maskin to explain how dry eye works and what comorbidities even mean and what they are and how they affect one another. Could you please do that for us, Dr. Maskin?
Absolutely. And it's important to achieve success. You have to have a frame of reference, a foundation concepts that explain the development of dry eye and MGD and thereby how to reverse it. So the first thing we'll talk about are comorbidities. And we're going to have a slide here. This slide is from my book. This is so important. This slide, this illustration shows this hub and wheel illustration of dry eye. Meibomian gland dysfunction is the centerpiece. In my experience, it is the centerpiece of dry eye. It's been shown to be responsible to be the major actor in up to 90% of dry eye cases, approximately 90%. Now, if we look at MGD, we find that the meibomian glands are impacted by a number of other comorbidities. So each spoke in this wheel is a separate comorbidity. And a comorbidity just means another disease, another condition that creates inflammation. And the inflammation can circle back and lead to the periductal fibrosis, which is so critically important of a concept to understand. Periductal fibrosis, as we'll see later, is scar tissue that's wrapped around the duct of the meibomian gland. So in this illustration, you see I've broken down different comorbidities into 4 different categories: mechanical, superior, and there we have very common conjunctival chalasis at 12 o'clock. Lag ophthalmos is next to it. And we can go around the clock, but I'm just going to mention a couple in each sector. Down in the tear-related sector, the aqueous tear deficiency, very important. Further at 6 o'clock, the iatrogenic category or sector, ocular surgery is very common, LASIK surgery, other refractive surgeries, even cataract surgery. And then on the inflammatory side, allergies, anterior blepharitis, such as Demodex, all these are very, very important. So this is not a complete list, but these are some of the major comorbidities that we see. And each of these needs to be identified really ideally in the initial evaluation. I should also, before I move on, the outer rings are also important. The superior outer ring are systemic comorbidities such as non-autoimmune, autoimmune, and iatrogenic. Iatrogenic here being things like Accutane, medications. Down below, inferiorly, the cofactors, stage of life, the environment you're exposed to, lifestyle, and diet. And again, diet, of course, things like caffeine, saturated fats, simple sugars, and so on. Very important to understand, again, this is not an all-encompassing list of comorbidities, but the point is it gets you started thinking about, okay, what are my comorbidities that could lead to surface inflammation that would then exacerbate or initiate a periductal fibrosis, which is the proximate cause of meibomian gland dysfunction. It's very important. And the reason, I'll give you a little practical example, is that I would rather treat inflammation of the ocular surface by identifying the comorbidity and targeting the comorbidity. Much better to do that than treat with ocular surface or treat with topical steroids or other so-called anti-inflammatory medications or other procedures that target inflammation. If I can identify the root cause of the inflammation and target it, for example, aqueous tear deficiency, I would much rather target the aqueous tear deficiency and eliminate that than to treat it with procedures, steroid medications, or other inflammatory medications and drops to reduce inflammation, because ultimately that's not going to help my aqueous deficiency state to use anti-inflammatories. So that's just one example. Same thing with allergies. Same thing with anterior blepharitis. I want to treat the source of the anterior blepharitis, whether it be bacteria or a Demodex. Allergies, in that case, I can treat with topical allergy medication. But again,
60.
things like IPL, which is non-specific, it's non-specific and really doesn't treat an allergy, doesn't, treat the aqueous tear deficiency. So you're not going to get the root cause of the disease conquered, and therefore the disease will continue and progress. Okay, that's an important point to make.
All right. So can you again address, like, for myself, what I talk to a lot of people about is my real dry eye disease is aqueous tear deficiency. Myself, my lacrimal glands are atrophic, they're shrunken, they're diseased. I don't produce basal tears. That affected my other comorbidities, which, because of my dryness in my eye, and a lot of people don't understand that because they have meibomian gland dysfunction, and they're saying, "Oh, I just need to get probed." And I ask them about their Schirmer score, and they say, "Oh yeah, it's 0, 0." So they're not producing any basal tears. And how does that affect meibomian gland dysfunction or conjunctival chalasis?
Yeah, so this is an example of what I was referring to. I can probe you. What's the purpose of probing? Let's start there. And we're kind of getting ahead of ourselves, but so let's not go too far afield. But the purpose of probing is to restore the integrity of the meibomian gland outflow tract, which means release the periductal fibrosis. And you can hear the pop. It's all about the pop. If any of you, my patients been probed by other doctors, successful probing, you're going to hear those pops, and that's release of the scar tissue. And that alone will restore the integrity of the gland for 1 to 2 months alone. In other words, if you don't treat your comorbidities, you'll still have a couple of months where the glands are intact, the outflow tract is intact. But that's where identifying and treating the comorbidities are so important. If you don't treat the comorbidities, then the inflammation from those comorbidities will cause those glands to close up again.
Right.
So you probe, but then you have to treat the comorbidities. Like in your case, the aqueous tear deficiency, so important to have identified it and then target it with specific treatments. And that's what we've been focusing on. And that's what we've been able to do. So,
So let's back up a second.
but the
We
fact,
did get it.
but it should be clear that the probing is designed to restore the integrity of the outflow tract. That doesn't necessarily mean your symptoms will all go away. The symptoms from a blocked meibomian gland will go away, okay? But if you have other comorbid diseases like aqueous tear deficiency, allergy, anterior blepharitis, they need to be treated as well because they're causing their own symptoms in addition to creating inflammation that will exacerbate your meibomian gland disease.
Got it. Right. Okay. And let's talk about more, what is scar tissue? So I plate out there: paraglandular fibrosis, periductal fibrosis. All of these are all the same definition of what scar tissue is, because this is a huge misconception. So I would say 80% of the people that talk about it, they say, "Oh, my doctor said that I have clogged glands." And I right away, that's a target that I see, and I will also always address and say that, it's not really a clogged gland. So can we talk about that?
Yeah, I would begin with the paper I published in 2019, and we could pull up the front page. This is an article. Let's go to the article first. And in Cornea, I published it in Cornea in 2019 on the expressible. Yes, maybe even zoom in if we can. No, the expressible right there. Zoom in to the title at least. And basically, expressible glands have occult fixed obstruction. So it's a peer-reviewed paper we published in 2019. And what this shows is that there are, and this is, again, you can see over 11,000 glands that we analyzed in 404 lids. But ultimately, as we show deeper in the paper, if the scar tissue, and Claire, if you can go ahead and show the actual image, figure 1 from the paper. What we show here is an image of the periductal fibrosis. So you can appreciate what we're talking about. So thank you. So this in A, let's start here. In A, we have a distal duct of the meibomian gland. The center black oval is the actual central duct. It's the lumen that through which the oil will flow to reach the lid margin. And that's surrounded by the duct wall. The duct wall are epithelial cells, okay? Epithelial cells in that duct wall, just like skin, epithelial cells. And if you would, Claire, can you outline some individual cells so people can appreciate those are individual cells? You can see the cell membranes between this actual individual cells. Yeah, right in there, right around the, so those are, and now those cells, mind you, that Claire's pointing to, those are the older cells. Those are the more senescent cells of the meibomian gland duct wall. The basal cells, the younger cells, are out in the periphery, and maybe you can show those right in there. Those are the basal cells along the what's called the basement membrane of the duct wall. So B is deeper than A. So as we go deeper in this gland, we're looking at the lid margin into this gland. And now at B, we're about twice as deep at 112 microns deep. And we see that the scar tissue, let's go back to A if we can, at 12 and 3 o'clock, those are sheets of scar tissue. In B, we see that scar tissue now is organized. Now we're going deeper. It's organized into a tight belt that is choking off the flow of the oil. You can see the lumen is now collapsed. It's no longer dark black, it's now collapsed. And that choke point prevents the oil from flowing to reach the orifice and lid margin. Now, the point is that this scar tissue can occur anywhere along the length of the gland. So if we go back to the figure showing different depths of scar tissue and the risk to the gland. Okay, this is an example. This is from my book. And you could see, for example, in the complete distal obstruction, CDO, that ring of scar tissue there is right inside the orifice. So in that case, the gland tissue, the acinar, thank you, the acinar tissue, which are those outpouchings that make the oil and send the oil through the central duct to reach the orifice, none of that can get through that choke point. Pressure builds up, and if we don't release that scar tissue, the entire gland will undergo atrophy, as we see right over here, whole gland atrophy. The entire gland becomes atrophic. Now, if we have the scar tissue more proximal, we call it CPO, complete proximal obstruction. There, notice in that case, it's behind at least one course of acini. Okay, and those outpouchings that are in front of it will make the oil, and that oil will travel through the central duct, exiting the orifice and up here on the tear film. Today, I've been talking about this for over 20 years, and this concept still has not been understood and recognized. Meaning, just because the meibomian gland can express, it does not mean the gland's healthy. And that's what the cornea paper was about. Expressible glands in patients with MGD are only seemingly healthy. If you probe these glands at different depths, you'll find that over 90% of these glands will have periductal fibrosis somewhere along the length of the gland. In this case, with proximal obstruction, if we don't release that scar tissue, you're going to lose the proximal piece behind it. And then you'll wind up with a short truncated gland.
Which
Okay,
everybody
so
sees in their myography, if you've ever had a myography, and always posts on social media, what do my glands look like? And you see them short and stubby or completely gone in the myography.
so it's very important that to understand that just because your glands are expressible, if you have MGD, there's over 90% chance, I should say this way, over 90% of your glands in your lids have scar tissue, periductal fibrosis, somewhere along the length of the gland. So the best thing to do is to obviously release that scar tissue, manage your comorbidities. Does that help explain that, Matt?
Yeah, so let me ask you a question about another huge topic that is always presented is the IPL and how what it's doing to the gland, because as you know, the mainstream doctors are all jumped on the IPL, and every single person that goes to an eye doctor that gets treated for dry eye will buy a whole block of IPLs. And I always try to explain to sufferers that you need to probe the gland first to restore the integrity of the gland so it stops dying off and it'll start regenerating and producing meibum. And it's a huge controversy because they will say, no, my doctor said I need, 20, I need 10 IPLs or 4 IPLs to feel something. And I try to explain that from what I've learned from your book and from you is that it'll treat the symptoms, but it will not release the scar tissue and your glands will die. Can you educate us on that, please?
Yeah, so it will not release the scar tissue. It doesn't do anything for the periductal fibrosis. So that's the first, the key in managing this disease is number one, identifying the comorbidities, treating the comorbidities, and when it comes to MGD, to release the scar tissue, use good lid hygiene. Very important to start with that approach. IPL, people that do IPL talk about it, how it reduces lid inflammation and the caliber of the vessels in the lid. And that's fine. That's their approach and how to manage this. Um, so I think that as far as what works for me is to go ahead and release the scar tissue and treat the comorbidities. That alone, number one, it restores the functionality of the glands and also reduces the inflammation. So I focus reduction of inflammation by identifying the source of the inflammation
And
and target the source of the inflammation, and that's how I achieve the success I achieve. But if we start asking, if we think about what actually is the meibomian gland, what is the probing actually doing for the meibomian gland, we can talk about that.
all right, okay, yeah. So let's go on. So I think you explained that well. Everybody understands that. I understand it. I hope everyone does. So, what exactly is probing doing to the meibomian gland? Please explain that.
Okay, just as an aside, if listeners, viewers, if they have a question that arises, they can, send a question to us, right, live while we're discussing these topics.
Right. And
Okay,
yep.
how do we find the source of inflammation? Let's quickly, Yuval. The way you find the source of inflammation is with a good examination, a good rigorous examination. Just as an aside, I published a paper a couple of years ago showing the reversal of neuropathic pain because there were multiple occult, meaning non-obvious, surface diseases, meaning comorbidities that were not identified by many, many different physicians that, when identified and treated, was able to reverse patients' neuropathic pain, if the patient ever had neuropathic pain. They met the qualifications of neuropathic pain with the proparacaine test and so forth. So it's so important to have a good, rigorous evaluation by an excellent diagnostician to identify your comorbid diseases. So as far as what probing does to the meibomian glands, let's go ahead and Claire, if you pull up the article from last year, this is a very exciting finding we reported, again, the peer review literature. So we found that meibomian gland probing stimulates a proliferative epithelial response resulting in duct regeneration. Okay, so if we go to figure, let's see, let's show the regenerative capacity of probing. Let's go to the figures here. Okay, this one here. Let's talk about this one. So we report basically ductal regeneration. So you see here in A, it's a meibomian gland distal duct by the orifice, 81 microns deep. You can see the sharp, flat borders due to the periductal fibrosis. All right, that's an A before probing. And then post probing, again, same gland. Here we have tremendous rounding up of the meibomian gland. This is at half a month, basically. The gland rounds up. There's a tremendous and proliferation of the ductal epithelium. You can see it. It's a 25% increase in duct wall thickness due to the proliferation of the basal epithelium. And we have a concomitant 75%, greater than 75% increase in lumen size. That means we're able to deliver more oil to the tear film because we have a greater outflow capacity. Now, I think what I want to, and I want to also make one additional point here. And the follow-up, the increase in duct wall thickness peaks at 1 to 3 months. 1 to 3 months, okay? And the same with percent increase in lumen. It peaks at 1 to 3 months, okay? That's in D, okay? And again, we're looking at, for example, increased duct wall thickness peak at about almost 40% increased duct wall thickness, an increase in lumen size over 100, about 170%. Now, if we go to the slide, the image of the track of the meibomian gland, I want to go over what's actually happening here. It's amazing. So this is from the same paper, and what we see here in C is a meibomian gland prior to being probed, and D is post-probing and E is post-probing. This is, we're talking about within a half hour after probing, we went ahead and reevaluated the same gland and to show these findings. I want to show you that this is a little basic science. If we look at in C, the duct wall thickness, I mentioned before the cells immediately surrounding the lumen are old senescent cells. Okay, those are old senescent cells, and the younger youthful cells are basal epithelium attached to the basement membrane out in the perimeter. Okay, so when we probe, essentially what we're doing is we're exfoliating the older cells. If you were to go, for example, to have a facial, and an esthetist does a facial, what they're doing is they're exfoliating the older surface cells, allowing the basal younger cells to proliferate and give you a youthful appearance. Well, this is what's happening when we probe. The skin, of course, is flat, whereas the meibomian gland duct is tubular. So in the meibomian gland duct, which is tubular, the old senescent cells are wrapped around the lumen, and the younger healthy cells are in the periphery at the basement membrane right there, attached to the basement membrane. So when we probe, you can see in D, some of that material is exfoliated. We basically exfoliate the old senescent cells. And in E, you can actually see the track of the meibomian gland probe. All right. So what we've done is essentially to debride or exfoliate the old senescent cells. And by doing that, we activate the basal epithelium, leading to what we saw in the last slide, that huge proliferative response, that regenerative response of the duct wall. As an aside, you can see in F, a 4 millimeter meibomian gland probe safely within the central duct of the meibomian gland. You can see some, the acini in some areas blocking some of the image of some of the probe itself. So this is important because some people out there are saying, well, if you probe, you can transect. You transect, you basically cut through the duct wall and you create more problems. And this is important to understand. No, that's not right. We show here the track of the meibomian gland probe inside the duct wall, exfoliating the old senescent cells. And so there's no transection of the meibomian gland duct itself. Very important. And therefore, it doesn't cause any scarring. Probing does not cause scarring because we remain in the epithelial compartment of the duct. Okay. So that's also a very important concept because there's a lot of misinformation out there. So in addition to the mechanical release of the scar tissue, which everybody knows about, you can actually hear the pop. It's all about the pop. Anyone who's had probably knows there's a pop, and that releases the scar tissue, and that leads to um, the the image, Claire, of the XLT versus LT. I think it's important to go over that.
A friend of mine from overseas, that was one of his biggest questions on XLT. What we mean by this is lid tenderness and non-lid tenderness with MGD.
So when a scar tissue, we showed the scar tissue earlier in a previous figure from the peer-reviewed literature. Um, that scar tissue chokes off the flow of the oil pressure builds up behind it, and that's manifested as lid tenderness. That's a mechanical cause of that symptom. When we release the scar tissue with the mechanical act of probing, the pressures are now able to equilibrate. Since there's no longer scar tissue there choking off the flow, pressures equilibrate, and with that, the lid tenderness goes away immediately. So the red graph is only lid tenderness, patients that have lid tenderness only, immediate relief of lid tenderness. Now, how about patients with burning, stinging, photophobia, other symptoms of MGD, excluding lid tenderness? And this is fascinating because this is something I noted early on, but I couldn't figure out why some patients' symptoms took a few months to reach their resolution. Okay, so you can see in the blue, so these would be symptoms excluding lid tenderness. In the blue, we did get an increase in comfort immediately, but only 36%. But notice it took approximately 3 months to get to that like 80% level of resolution of symptoms. So I figured that there's something happening at the cellular level that I didn't understand yet to explain that 3 months requirement to improve the symptoms. And this dovetails into the image we just showed. If we can go to that image where we just showed the regeneration, which peaks at 3 months again. So again, if you, yeah, see there you go and see the increase in duct wall thickness, which means the peak regenerative capacity is in that 1 to 3 month period where the gland duct regenerates, okay, and the maximum outflow capacity also at 1 to 3 months. So that explains how come patients with XLT have their peak comfort at 1 to 3 months because of this change, the regenerative change in the meibomian gland duct wall. So basically, it's improving the functionality of the glands.
All right, let me ask some questions here, Doc, please.
Okay.
So this is getting very technical, and I understand it because I've been doing this for a while and reading the book. But for everybody else out there, I want to try to give a little summary of everything that we talked about so far, just so I can understand it better and maybe someone else will. So when I have my probing, so I'm going to talk about myself. So I have aqueous tear deficiency, severe. And a lot of people are asking about a Schirmer test. And I want to get to all the testing, but I'm just going to give a brief summary. And I think this is a lot of people that I talk to has aqueous tear deficiency. So with myself, with my aqueous tear deficiency, it creates a discomfort in my eye and a chain reaction in my eye that I try to keep my tears in my eyes by closing my puncta. Okay. A lot of people don't understand that. They tell me they have severe aqueous deficiency. They keep their puncta open. I tell them they have to close them because that will then create why I need probing sooner than later. Try to follow me on this now. My aqueous tear deficiency, I don't produce basal tears. My eyes are terribly dry. We close all four of my puncta, and that maintains some tears in my eyes to knock out the inflammation. Because if I don't do that, it inflames my meibomian glands and makes me have to be probed more so than annually?
So like we said in the beginning, these basic concepts. Aqueous tear deficiency is a major comorbidity, a major disease which creates surface inflammation, which in turn will initiate or exacerbate meibomian gland periductal fibrosis. So we close the punctum. I personally much prefer cautery to plugs. Um, and I would, depending upon how severe the aqueous tear deficiency is, I'll close all four punctum if need be. Now, I like to perform what's called a superficial occlusion, which enables me to adjust the opening of the punctum if necessary. But I think it's very important. It's essential. Now, so I have a little different view on that. Others talk about toxic tear. In my experience, this is not an issue. It's not an issue, and it's more important to have sufficient moisture on the surface of the eye than to be lacking in moisture. In fact, I would say it's critically important for the health of the surface of the eye to have adequate moisture. You can imagine without saliva what's going to happen to your teeth and gums. You have to have adequate moisture. If you have issues with delayed clearance, meaning if things get in your tear film and stagnate, you can flush the eye out, you irrigate a couple times a day. If necessary, I can even, if you have too many tears, I can again adjust the opening of the punctum because I do a superficial closure. I can adjust it, open up a little bit to avoid any issue with irritation from, irritants or allergens. In addition, in the case of allergens, to use a topical allergy drop. But it's very important to have adequate moisture. I prefer cautery over plugs because again, plugs can cause numerous problems. Number one, mechanical, rubbing. They can fall out. They can dive deeper in and cause internal scarring of the canaliculus. They can cause a number of issues. They can be seeded with bacteria, and then you have intermittent seeding of the aqueous surface. You can wind up with conjunctivitis or infectious canaliculitis. So that's my take on that.
On the aqueous end, on the aqueous
On
portion.
the aqueous, yeah.
Can you see this?
So it's basically sterile saline without preservatives, and you can get it on Amazon.
Right.
It's
And
irrigated.
people, I just spoke to a person today, a sufferer today, saying that they flush themselves with tap water. They flush their eyes
No,
with tap water.
don't do that. I had a patient, a patient of mine, a few years ago. She was doing beautifully, and to save money, in the shower, she was irrigating her eyes in the shower. She came in out of the blue. My eyes have been red the last couple of weeks, and I had to be, detective to sort out, what happened. When is your dryness worse? Well, when's your symptoms at its worst? After my shower. Let's do, just to sort out what's happening. It turned out that she was basically using the shower tap water to irrigate her eyes. It's got chlorine in it as well as other impurities. Not a good idea.
Right. Okay.
As soon as we switched her back to the irrigation with sterile saline, non-preserved, she did beautifully again. So yeah, the point is here, your doctor needs to be a real good diagnostician, a real detective to help you sort out your comorbidity. I mean, that's not one of the first things you think of is someone, showering water, putting shower water in their eyes to rinse their eyes out. Again, you have to be a detective. The patient needs to be a detective too, and kind of sort out and learn how to evaluate oneself and analyze oneself. When do my symptoms occur? What am I doing when they occur? Or the hour before they occur? And that helps, because you should partner with your doctor together to sort out your comorbidities and particularly your environmental comorbidities and behavioral comorbidities that you're not necessarily aware of.
There was also a question about why you need annual probing.
Because we can go back to that figure showing that at the end of the year, no, I should back up. We have peak functionality at 1 to 3 months, because that's when our peak regenerative change in the duct wall occurs. So peak regeneration of 3 months, peak outflow tract capacity at 3 months. But over the course of the year, you can see how it comes back toward baseline. It's still about 15% or so above baseline in the duct wall thickness. So the reason is because you cannot avoid comorbidities. Sunlight's a comorbidity. It can create inflammation in the meibomian glands. The quality of air, your pollutants. You may be exposed to something. You may be exposed to something you're allergic to. You maybe walk behind a bus. There's just so numerous comorbidities that can occur that will lead to the closure of the meibomian gland ductal, of the central duct of the meibomian gland. And the analogy is like dental analogy. I mean, you can't get rid of the plaque, and plaque will form. You cannot prevent that. So in the case of meibomian glands, if you can control your comorbidities, an annual probing serves well to keep your glands maintained, keep your meibomian glands healthy, prevent them from undergoing atrophic change. And it's turned out to be, again, since I've been doing this over 20 years, key to success.
Okay, so I want to talk a little bit about, someone had asked me about a Schirmer test, why it's done, and the three different types of tiers of a Schirmer test with numbing drops, right? So why do we do Schirmer tests with numbing drops?
I like to identify the basal tears. So to numb the eyes, and then what's the tear production in that condition? Again, that to me, that's the most important finding in the aqueous tear deficiency realm. I want to know how much tears are being made at baseline. It's also very important the way the Schirmer's test is done, not just with numbing, but you may need to repeat it. I call it serial Schirmer's test that I describe in my book. I've had many cases over the years. The first Schirmer test with anesthesia looked normal. Might have been 13, 15. I did it again, repeated it. Lo and behold, it was down to a 2. I'm thinking of specific patients in my mind. So there's a way to do a Schirmer's test, and there's a way to analyze it, and it's all laid out in my book. It's probably, again, when we have these sessions on an analysis or testing, diagnostic testing, we can get into that depth of the nuances of testing and how the conclusions that the doctor draws are essential to successful management of that comorbidity. But I think right now, I think it's maybe a little bit more than we want to delve into.
Yeah, we're gonna have other, like I had mentioned, we want to do this again. We're gonna move on to other sessions I want myself to go over every test, to actually maybe even show how Dr. Maskin performs the test, because one of the major things that I find when I speak to sufferers is I explain to them, have you had a Schirmer test? Have you had a serial Schirmer test? Have you had a meibography? Have you had a conjunctival chalasis test? Have you had a lipiview? All of these different things. And most of the time it's no, right? They go, oh, well, I just need to be probed. I need to find a probing doctor. I said, well, that's great. You could just be probed, and that'll restore the ductal integrity of your glands. But if you're not tested for your comorbidities, you're wasting your time, you're wasting your effort, you're wasting your money.
I tell you, I have patients that have been probed. They do well for 2 months, and then they don't do well. So they come to me, seek me out, and they say, this happens with some regularity. My doctor did a good job. They probed me, but 2 months later, had a probe again. He's probed every 2 months. I said, well, there's missing comorbidities here, and inevitably there are missing comorbidities. And once those are found, identified, and adequately treated, after targeting it for treatment, then the patient is back to the annual probing and no more frequent than that.
And I try to explain to them, because a lot of people say, well, I got probed, but I'm not better. And that is put out there a lot. I've even have people, and I was probed and I don't feel better, and I feel like I wasted my time and my effort and my money. And I've even reached out to you about a few of these patients, and your big thing is you need to follow up, and there's going to be other comorbidities that are identified. And could you please elaborate on some of that?
If patients don't do well with the approach, it's from a lack of follow-up or non-compliance. or they're not, all the comorbidities are not being addressed. There are some patients that don't want to have their chalasis fixed. There's patients that insist on having their their pets that they're allergic to sleep with them in their bed. Um, I've had a patient who did beautifully, and then their trichiasis or their distichiasis lashes, their basically lashes grew back that rubbed the eye again, and they mistakenly thought that they were getting worse, but actually all they needed was to have their extra row of lashes removed again. So there's a reason if the patient has ongoing symptoms, there's a reason, and the most important thing is to follow up, share the new symptom or any new symptom or ongoing symptom, and because inevitably it's one of those three: either there's no follow-up, so you don't learn what's wrong, or two, non-compliant with directions, or three, not addressing the comorbidities.
Right. Okay. So we all understand that. All right. I know we're closing on some of our time. So that there was something that I wanted to talk to. We're going to get to some questions, but I had a sufferer friend in Texas who I went through this all with them because I'm pretty well versed in it and I understand the disease. And I explained to people about managing their expectations. And you have to understand that you have a disease and that with Dr. Maskin, he will put your eyes back together anatomically. And it's, many pieces of the puzzle. And I explained to him about ductal fibrosis, and he had listened to me and he thanked me. And then he shoots me a YouTube video that was put out by Dr. Toyos and about how IPL is what he's found that most of his patients don't have ductal fibrosis and that you could transect the gland and all of these things. Can you please clear this up for us and explain to us why this doesn't make sense? Because
Okay.
to me, it doesn't.
All right. So let's put up a slide, the image of there's an image here we have from that video that you shared. So on the left is an image from that video that you sent me. This is a confocal that the doctor did, and saying this is on my bone gland. There's no markings here to suggest this is on my bone gland duct. You can see on the right. You can see on the right. This is A, or in my images A and B. This is from my paper that we talked about earlier. You can see the my bone gland duct wall. You can see the individual cells. You can see the basement membrane of the duct itself. You can see the lumen, of course, but this is, clearly, and you see the scar tissue. So you can see the scar tissue at 3 o'clock and at 12 o'clock. And then in B, you can see how the scar tissue has become organized into a tight belt that's choking off the flow of the oil. But here's a duct wall. From the video you shared, I don't see any epithelium like we show in our peer review paper. So, in my view, there's really nothing to suggest this is a meibomian gland tissue.
Now,
And
this is excuse me for 1 second. This is a image from a confocal microscopy, which is a microscope that looks into the meibomian gland from the lid margin. Am I correct?
no, that's how I use it, and that's what we're in A and B. That's what we're showing in A and B. That's correct for my work that
Okay.
we published. Now, from in the image from the left from the video in social media, that looks like it was done through the conjunctiva, looking for my meibomian gland tissue for the conjunctiva, not at the lid margin. And the problem with that is you cannot visualize the meibomian gland duct if you're looking at it through the conjunctiva, because the confocal microscope only reaches about 120 microns depth, 130 microns depth at most. So this meibomian gland duct is beyond the reach of that. Meibomian gland duct is probably about 200 microns. So this could be a number of things, but there's nothing here to suggest that's a meibomian gland.
Okay.
And so there you have it. We show, as we mentioned, we show the scar tissue, periductal fibrosis. We have a peer-reviewed paper we've reviewed with over 90% of glands and lids with MGD have periductal fibrosis. So we have our peer-reviewed literature that shows this definitively.
All right. So this doctor says on the video, I just took some notes. I watched it quick. And the doctor says that he doesn't find any of his patients have fibrosis, is the first thing, right? And I know from my own experience, I had fibrosis, terrible fibrosis, because when I first went to see you, I had 3 or 4 of my glands working. And when I left you that day after being probed, my tear film was measured on the LipiView, and it showed at 100% that all of my glands, most of my glands were putting out. I had 20 plus or minus in each upper and 18 in each lower, that after being probed were actually producing meibum that same day after probing. So how a doctor is saying that he doesn't find any of his patients to have fibrosis is just, I can't even understand how that could be.
Well,
Right?
he's
So
not
I'm
he's
sorry
not
for the
looking.
comment on that.
Yeah, he's not using the confocal at the lid margin. Number one, number two, he's not probing. So he basically doesn't know. He doesn't know what he doesn't know regarding his patients. Um, and as we published in the peer review literature.
Okay.
So
Can IPL release scar tissue? Because this
um,
is the big question. Everyone out there is I have to get IPL. I had 30, 40 IPLs. It reduces the inflammation. And I explained to them, but you have to mechanically release the scar tissue first in order to restore the gland. And everyone's like, nope, my doctor told me that I need to have IPL performed, and that will help. That is the go-to treatment for MGD.
remember, the scar tissue is not released by IPL. Probing works beautifully on patients who failed IPL. It works beautifully on patients that never had IPL. Remember, IPL is usually accompanied by expression, and that will deliver lipid oil from glands whose scar tissue is more proximal. So it gives the patient it's actually a confounding experience, because if you ask patients very carefully, um, you can have more tear lipids, you can have reduction in symptoms because you've delivered oil from in front of a scar tissue, like we call CPO. So here's the CPO, and there's scar tissue there, which Claire will circle. And in this case, there's your scar tissue, but you have acini in front of it. So you do a IPL and a expression, and that oil is going to come through there into the tear film. But again, as our paper showed, that gland is only seemingly healthy. You have scar tissue still, and over time, the part of the gland behind that scar tissue will undergo atrophic change unless you release the scar tissue.
Right.
That's an
So
important point.
what I took of that is that I'll explain it, and you tell me that I understand it properly. So if a patient is presenting with meibomian gland dysfunction and the symptoms of that, and they go to see a doctor that will perform IPL, they will go in, they will have the IPL performed, and one of this particular doctor's must haves is expression after your IPL. So what you're saying is if you have scar tissue that's deeper into the gland and you still have some healthy gland tissue, when you have the IPL, it will heat up the meibum. And then when you express with that forcip, it will introduce some of the meibum into the tear film and give you a relief at that point in time. But it is really doing an injustice because the scar tissue is still closed in the gland, even though it's further up, and everything behind that scar tissue will die off. And that's what you will see in the meibography.
Yeah, you'll have because you're elevating the pressure further behind that scar tissue. So the patient doesn't realize that they have, they can have in some cases better reduced symptoms, but at the same time, the more proximal part of their glands are exposed to high pressures, which can ultimately lead to atrophic change. I mean, it's just, patients come in very frequently. They've had a dozen, 2 dozen, 50 IPLs, and they're really it's not surprising because again, they're not addressing the root cause of the disease. That periductal fibrosis is so important to address. I want to, if I can, Matt, someone, I think you mentioned, someone asked about being having symptoms of MGD after being hit in the
Yes.
eye.
Yes. Yeah, Bree, a friend of mine, she had some, yes, was hit in the eye, was punched in the eye. I was trying to find her question, but yes, after some type of hit in the eye, she had symptoms in her one eye only.
So the answer is yes. You get blunt trauma to the lid, you can absolutely lead to inflammation and periductal fibrosis, and that lid should be evaluated carefully and probed. Um,
To release
that's
the scar tissue.
absolutely just like all these other comorbidities. Blunt trauma is a comorbidity, can lead to periductal fibrosis.
Can you also talk about this particular doctor that I watched that YouTube video? Was infuriating to me because it goes against everything that I learned and I taught and I've read and I've researched. And he says that you can transect a gland. Now I had to look that up. What transect means because you doctors tend to have your own language, which I, the dumb electrician, just can't understand. And it's to cut or divide something transversely across its length. Now, from what I understand, the gland itself is pliable. It moves when you probe. It's you. Have you ever transected a gland in the thousands of probing that you've performed?
No, it doesn't happen because Claire brings up that image again, and this is something we went over earlier, but it bears repeating. You can see the track of the probe. Yeah, you go. Thank you. You can see outline the actual track of the probe right there. The track of the probe for 360 degrees. There you go. So you're in the duct wall. You're inside the duct wall in the epithelial compartment, and so therefore you're basically exfoliating the old senescent epithelium. And there you go. That's again. That's what leads to the regenerative duct reaction by exfoliating the old senescent cells. So, and mind you, notice this. We're talking about over 90% of glands in lids with MGD have periductal fibrosis. This is not keratinization. This is fibrotic change. This is when you place a probe inside the central duct through the orifice into the central duct of the gland. You hit a firm resistance. Okay, it's a fixed resistance. It doesn't give way. You have to give it extra energy to pass it through. You hear that pop, and the oil, if the gland's a working gland, the oil will come out and trickle out along the length of the probe, and the patient feels that relief. This is not keratinization. Keratinization or thick meibum, which are the two conventional concepts which traditionally had explained obstruction of the meibomian glands, would not give a fixed resistance to a probe being passed through that central duct. So this is a very important concept. Treating with medication to reduce keratinization will not release the scar tissue. Okay, so that's an important concept to understand.
So to all of the sufferers out there that always come back at me and will say, "No, I'm going to buy a block of IPLs and I need the IPL. My doctor said I need the IPL." Dr. Maskin has given us proof here that probing first and foremost. If you want an IPL complimentary afterwards to, you know, maybe it feels better, that go for it. Get it done. If your doctor insists on doing it, doing it. I myself have tried it. I had 7 IPLs before I met Dr. Maskin and 7 lipoflows before I met Dr. Maskin. All it did was make my suffering worse. And there's a reason for that that Dr. Maskin could explain, but I'd like to go on something else first. Is I had the 7 IPLs, I had the 7 lipoflows. I found Dr. Maskin. I was treated. I was probed. I was cauterized the first day I saw him after having all the tests, and discovered with me what was going on. And then I had gone back afterwards because I had read that study, Dr. Massin. There's a Wang study of 2019 out of China that some of the patients, there were 3 separate groups. There was a group of IPL only, there was a group of probing only, and a group of probing first and then IPL. And I bring this up to a lot of the people, please go and check this out and read this study. And so I read the study and I'm like, man, I'm going to go get IPL afterwards because I thought I knew better. So I had the 7 and the 7. I go and I see you. You probe me. I fly back home and I go and I have 2 more IPL rounds. And I had expression afterwards. And the doctor who did it squeezed my gland so hard. It was very painful. And by the 3rd month, I was suffering again. And I had reached out to you and I said, you know, I'm just as bad as I was before you probed me. I need to come and see you. I flew down, I saw you, and you checked all my glands and you said, oh my God, what did you do? Your glands are not functioning again.
Yeah.
And can you explain? And then I needed the probing again. Can you go into that and you explain that? Because that's been a huge misunderstanding.
Well, again, you know, the act of expression itself is very traumatic to the lids and can create inflammation. And I think, you know, this is something that, again, we may want to take up in a future time as well. But ultimately, you know, your case, you know, the probing is essential for your meibomian glands, and aqueous tear is key as your comorbidity. And you know, we don't want to impart trauma from expression. Expression is very traumatic, particularly if if you haven't recently been probed. But even then, if you could exceed systolic blood pressure if you express. And if the doctor exceeds the systolic blood pressure, you basically can reduce blood flow to the glands and you release it. Then you have reperfusion. In other words, the blood flow returns. All this can create inflammation. So I hesitate, and I haven't found it necessary at all to successfully treat patients with dry eye disease. My focus is we restore the integrity of the meibomian glands, we treat the comorbidities with targeted therapy, and we achieve success consistently.
And so the IPL industry will put out there that that's what the IPL machine does, is it will help the inflammation. But from what you're telling me, with what I understand from you saying, is treat the root cause of the inflammation,
Yeah.
identify it, target a treatment protocol, and treat that inflammation. And there's no need to have IPL to treat that inflammation.
Let me explain something a little further if I can. Someone just posted asking about rosacea. The way I look at ocular rosacea is where the eye and surface of the eye is particularly sensitive to comorbidities, more so than the average person. The patient with rosacea is even more sensitive to the comorbidities, lack of moisture, aqueous tear deficiency, allergies, sensitivities, and on and on. So one has to be very rigorous in addressing and identifying and targeting comorbidities to succeed with rosacea. And again, it's very common. You see it all the time. And we're, again, very successful in addressing this disease. There was one physician, I think in New York, that wrote a paper about probing for rosacea patients. Again, excellent results. Again, it's the same approach. Probing to restore the integrity of the glands, release the scar tissue, identifying and targeting the comorbidities to succeed. So
I want to apologize to everybody. I know we kind of bounced around. We didn't rehearse this. This was just all right off the hip. And we went around and around with a lot of different ideas and a lot of different topics. Perhaps in the next one, we'll be more organized. Maybe our busy schedules will be able to.
Matt, let's take 10 minutes and just do rapid fire questions.
Yeah, that's what I was just going to suggest. Let's go right into questions because we spoke enough about myself and all right. So here's a question. We didn't touch on this too much, but CCH, conjunctival chalasis. We definitely have to talk about this, but what do you? Here was a question from Diane Backer, and what are your thoughts on the best ways of treating CCH? Dr. Giacomo has published articles about using RF. When I bring that up in my dry eye doctor, he says it isn't proven to work that well. However, his office doesn't offer that. So just wondering your thoughts on the success rates of using RF.
Yeah, for me, I like using the regenerative approach of excision of the abnormal tissue and reconstruction with the amniotic membrane. It's a one and done procedure. I don't have to repeat it. If you do more of a destructive procedure, then I see patients that have had that done that have it to be repeated. In my hands, again, I just excise the abnormal tissue and then reconstruct with the amniotic membrane. Any procedure that uses heat, that you don't have an amniotic membrane to reconstruct, there's potential for, fornix foreshortening. I personally, again, have great success with the approach that I use. You're able to restore the reservoir, the tear reservoir, and you also help keep the orbital fat, other tissues from prolapsing.
What does prolapsing mean?
Coming forward and eliminating that fornix tear reservoir. So in my hands, I like that approach that I use. I think we got a question about Stevens-Johnson.
Yep.
Again, Stevens-Johnson syndrome is a very challenging disease. There's acute management and chronic management, but these same guidelines are very important to follow as far as minimizing residual symptoms from Stevens-Johnson. And I think, those patients with Stevens-Johnson's, submit your questions and, specific questions. And if we don't get to them on this, go around, then we can, in future opportunities, future sessions, we can attack them.
Yeah, got a great question that I've wanted to ask and I forgot, and Bree just brought it up. Ingsleby, is confocal microscopy the only way to see periductal fibrosis?
You could, at the slit lamp, you can get a sense of periductal fibrosis, or I should say more of fibrosis around the orifice. You can get a sense of that. Sometimes you can see at the slit lamp through the conjunctiva that there's subconjunctival fibrosis, but you can't see details, obviously, at the slit lamp. You can't see details. You can see best details with the confocal, but ultimately the probing is really the best way to identify the existence of periductal fibrosis. And again, if you have MGD, over 90% of your glands have periductal fibrosis. So,
which would be identified from a mammography.
No, you cannot see periductal fibrosis on mammography.
But knowing you have MGD, like how would a person go in and say, "Hey, you have MGD"?
Well, I mean, MGD, I don't know that a patient could self-diagnose, although if they have rosacea, skin rosacea, they probably have there's a good chance that they have MGD just on that basis alone. If their lid margins tend to get red, symptoms related to the lid margins, itchy, burning lid margins, red lid margins. Those are things that, the patient, obviously lid tenderness. Most patients, they don't press their lids to see if they're tender or not. Um, so burning, stinging, sensitive to light, these are all symptoms of MGD.
Yes, evaporative. That was big with me. And okay, I want to go on to some more questions. Sorry, it was a good question. A lot of people did ask, and someone I spoke to out of California. How do you treat dry eye caused by Accutane?
The same way we treat all dry eye with that. If you remember, go back to the hub and the wheel, the glands need to be probed to release the scar tissue, and then you identify the comorbidities in a rigorous fashion, and you target these comorbidities with specific targeted treatments. That's the key. The treatments have to be specific and targeted, not a general, non-specific approach, which doesn't really eliminate the disease, but hides the disease. I have a patient now, he's from the Middle East, and they basically were treating with steroid drops to try to hide his disease. He tried to come off, and his symptoms returned initially after 3 months, then 2 months, then 1 month, and then he couldn't even get off the steroid, and then ultimately the steroids don't even help him. So don't mask the disease, identify the comorbidity, and target it with specific therapy for success.
Okay. Warm compresses, Nancy Holden. Warm compresses seem to make my eyes more dry. Is there something else I can be doing to keep the glands open and functional?
Yes, again, the reason why the warm compresses makes your dry eye worse is because you're increasing blood flow to those meibomian glands, which are blocked with scar tissue. So anytime you have noticed that warm compresses make your symptoms worse, you've got your periductal fibrosis needs to be probed, either for the first time or on a recurrent basis if you've been probed in the past. But that's a key tip off. If your symptoms are worse with warm compress, you got increased. You have periductal fibrosis, and the warmth is bringing more blood flow to a locked in area, a socked in area, and it just increases the inflammation, exacerbates your scar tissue.
Margarita Alatori asked, "Why are not why are not more doctors doing probing?"
Well, they don't realize how essential it is to management of MGD. And ultimately, the company I have, MGD Innovations, um, we're here simply because patients have invested in the company. Um, so we don't have a large budget. Everything that was invested by these patients is going to bring us to the point where we can have these devices, probes available, but there's not a lot of capital for the kinds of things you see, like, for example, with the IPL industry or the lipoflow industry, where these are huge companies that have, hundreds of millions or more to spend and to flood the marketplace with their material. So we're David and they're Goliath, and but we have the truth on our side as far as how to successfully manage the disease. Um, and so at some point in time, more and more folks will embrace it. They realize how essential it is for management.
Yeah, so when I first met Dr. Maskin, he explained to me about the business that he had started producing these probing kits so every doctor in every country and every state in the United States will be able to probe and can understand it. So you could go to your local ophthalmologist and be probed. And a lot of people don't know that and didn't understand that. People have come to me and had said that, well, Dr. Maskin's the only doctor you can go to get probed, and it's costly. And I said, well, that's not entirely true, but he is the inventor, and he started this business to be able to have every doctor in every single corner of the world be able to probe their patients. That's what MGDI is MGD Innovations. Uh, so here's an interesting one. What is causing my MGD? This is from Tracy Davis. What is causing my MGD? My glands to get blocked. Did we discuss that? The difference where a lot of people think their glands are blocked and inflammation from what? I have ruled everything out. Is it hormones?
Well, there's something there. There's a comorbidity there, and it may not be apparent, but it's there. And all I could say is don't give up because there's a reason why they're blocked, and the reason why, I mean, then there's it's periductal fibrosis, but you need to identify, you need help obviously in identifying the source of that periductal fibrosis, which comorbidities you have, and it may not be obvious.
Right.
It may not be obvious, so don't give up. The answer is there, just don't give up, and you'll achieve success.
Kerry Morrison, she had just posted, could you repeat what it means if I have MGD but no lid tenderness? I had probing a couple of months ago and haven't noticed any improvement yet.
Okay, there you go. So remember the three reasons why you may have ongoing symptoms despite probing. One, no follow-up. It sounds like you've had follow-up with your doctor. Two, non-compliant. You would know that, or unless there was a miscommunication between you and your doctor. Three, comorbidities. Not all the comorbidities were identified, and if they were, they weren't adequately treated yet. They weren't adequately targeted yet. Or you might have done something to exacerbate the MGD after the probing. You had an experience, Matt, where after your probing, you had IPL, and it just threw you back to the edge of the cliff.
Yes.
So there might have been something that happened after your probing to exacerbate it, which would be considered a comorbidity, essentially. There's a
Right.
reason. There's a reason that you haven't figured out yet. Don't give up.
All right. Another question was asked, like, how do you make probing not painful? So, just a little quick story. I was probed the first time ever by a doctor here, and I was used with no anesthetic, and oh my God, thought I was going to die. So, just explain how you do it, because that's what I explained to this person.
Right. So currently, the way I do it is I put some, I inject some lidocaine with epinephrine. Those patients that can handle epinephrine, non-cardiac patients. Cardiac patients, I just use plain lidocaine into the brow. There's a supraorbital nerve right there. And by injecting anesthesia there, you numb the upper lid. The top of the cheekbone is the infraorbital nerve, and you numb the lower lid. And by doing that, I also add some jojoba ointment, jojoba anesthetic ointment to the lid margins. Patients close their lid margins, and we start probing about 5, 10 minutes later, and patients do beautifully. Simple as that.
All right.
Those doctors that they cannot inject, optometrists, for example, they can use the ointment. The ointment I used for years and worked very well about 90% of patients, as far as obtaining, good anesthesia. I personally think that the combination is best because particularly if you have really thick scar tissue, that you have to release, the combination is best. But again, for the majority of patients, I think the jojoba anesthetic ointment alone suffices. The other thing is, once it's done the first time, subsequent, annual probings are easier as well. So it takes less anesthesia usually.
Easier for you to say.
Yeah.
Yeah. And I think it's a male female thing. Men are just more sensitive. Women seem to have a lot of higher pain tolerance because I know I don't have any pain tolerance for it. Mark Brandstein, how can you determine if a patient has corneal neuralgia versus clogged glands that might benefit from probing?
Excellent question. Is there more to it?
Yeah, a little bit more. So also, when is probing not appropriate for a patient?
Okay, that's simple. Probing is not appropriate if you do not have MGD.
Bam.
Okay, simple. As far as corneal neuropathy, it's an excellent question. I see so many patients who are diagnosed with neuropathic corneal pain that that are on gabapentin or on other treatments, that they come to me and literally I identify occult, meaning non-obvious, surface disease, maybe deep scarring, deep periductal fibrosis, maybe aqueous tear deficiency, and on and on. That when treated, when implemented, when targeting those diseases, they're able to have restored comfort to their eyes. So, you know, either they didn't have neuropathic pain in the beginning or they were diagnosed with it. And I think that sometimes if the doctor cannot identify the source of the pain, they just automatically, they just go to that diagnosis. Um, and that's unfortunate because then patients get put on these different medications that can actually have significant side effects. So how to differentiate? You just have to have a good examination, someone who is experienced in identifying comorbid conditions. Really, this disease really requires a good diagnostician, basically, who has time, who will spend the time to sort out these different comorbidities, because that's the key. You can be probed, and yeah, you can find out there's superficial fibrosis, there's deep fibrosis, and that's fine. That's important. That's essential to start with. But the comorbidities, that takes, as you've experienced, you really have to be a detective, and rigorous. Those that have these challenging cases, you need to have rigorous evaluations to identify those comorbid diseases, and that'll make or break a case. They'll restore comfort in your life or not.
Yeah, there's a young sufferer, Simon Hurst. He's become a friend. I follow him a lot. He's a young dad, and he's suffering horribly from corneal neuralgia, and he's on that corneal neuralgia site. And so many times I want to just say to him, can you please go see Dr. Maskin or any other doctor that could diagnose you with MGD to know if your glands are functioning or not, because that could be a life changing event. Um, anyway, you discussed this procedure. How do you? Oh, here's a good question. Kelly Prowl. How do you decide if a patient needs a 2 millimeter probing versus a 4 millimeter probing?
Okay, good question. Um, Typically, I don't usually do 4 millimeter unless I'm targeting a particular gland. This is fascinating. Um, a patient may come in and basically say, I've got a tender spot right there, and it's proximal. Okay. This could happen 6 months after probing. This could happen before the patient was even probed. But the the experience of probing has enlightened me and taught me so much about this disease, not just MGD, but dry eye. Those glands could get blocked, as we mentioned earlier, anywhere along the length of the gland. So when our patient has tenderness, particularly way up high in the lid at the most proximal part of my bone gland, that's where I use that 4 millimeter probe to reach there and release the scar tissue. And again, boom, just like that, the tenderness goes away. That's how powerful probing is. But routinely, I'll do 1 millimeter. If I'm not getting a lot of pops at 1 millimeter, that tells me, okay, there's deeper. I'll go 2 millimeters. Um, and so, but 4 millimeters, I typically, if I tell you what, if I don't have, if I'm not getting pops and at 1 millimeter or 2 millimeter, I'll go to 4 millimeter if the patient has MGD. And again, that's how I was able to identify that over 90% of glands have periductal fibrosis somewhere along the length of the gland, by going out to 4 millimeters in those patients that either did not have scar tissue at 1 or 2, or were still tender up higher on the lid. So 4 millimeters there if needed, but basically you do 1 or 2 millimeters is a more routine approach.
Okay. Why does this is from, I'm going to butcher this name, Julian Lenfant. Maybe it was good. Why does Dr. Masson think its techniques haven't been more widely adopted in and outside of the U.S. despite the studies he's released? Is it because probing technique is difficult to master?
Well, no, I think that everyone's busy doing what they do. Most doctors, most ophthalmologists, general ophthalmologists, corneal specialists, they're doing refractive surgery, cataract surgery. I think people are busy with what they do. Um, and and so you really have to want to learn how to manage this disease because there are many nuances about how to manage it. It's not just straightforward per se. Although once you learn it, then you know how to apply your knowledge and the nuance, and you achieve success. So you have to have a commitment, and I think the best thing to do is really ultimately to have dry eye fellowships. But we need you need people that are committed to dry eye. Um, and there are not a lot of people that just do dry eye. So uh, some of the larger uh, multiple physician practices are hire. I think they're hiring and having designated, dedicated dry eye specialists, and that's a start. That's a start. But ultimately, it takes a commitment. I laid a lot of it out in my book that was published in 2022, Your Dry Eye Mystery Solved. There's a lot of information there that really is, in my opinion, is essential. The concepts are essential to successfully manage this disease in a consistent manner. But again, you know, I mean, at a basic level, I think that it takes a commitment, and you have to have a doctor who's open-minded, who's not conflicted, who's willing to take in information and act on it.
A lot of people are coming in and asking about the technical aspect of it. I just want to apologize for everybody who committed to us and listened to this. That was my idea, to get technical in the beginning, because I wanted everybody to learn how this disease works. People are saying, "Hey, stop with all the technical stuff and just answer our questions." I get that, and we will, and we're going to do more than just this one, but I felt that was on me. I'll take the blame for that, because I felt it was very important that everyone learn how this disease works so they could understand it better. And
It's important, Matt. It's important, Matt, because when they go to their doctors and their doctors say, do this, this, and the other thing, if they're not empowered with the concepts, then then it's going to be a shotgun approach. Let's try this, let's try that, let's try the other thing, and they're not, and it's they're not going to have the success they want. If you incorporate the concepts, the foundational concepts, then you're empowered to ask specific questions, to look for specific therapies. It gives the patient some skin in the game, as it were, and they can help. For example, they tell their physician, I think I've got a comorbid disease. I think when I'm around onions, for example, I have a problem, or I think my lashes are growing back. If the patients start thinking about what their comorbid diseases are, then that will help the physician help them. And ultimately, that's what we want. We want a partnership between the physician and the patients to achieve comfort, success, and have restored lives.
and just to add to that, what I do is I've been in searching for other doctors, because people always ask me, well, are there other doctors that do this and do that? And I'm pretty well versed in how this disease works. And what I do is I search on the internet and I find doctors around the New York area, and I make appointments with them so I could talk to them and see if they're willing to learn, to see if what they know. And the funny thing is, I go in to see a doctor, and within the first 5 seconds, I could tell how much they know about dry eye, because I'm so well versed in it. And I'm trying to find a network of doctors that would be willing to. I've even gone as far as to meeting with ophthalmologists and discussing dry eye at length, and then I would explain to them Dr. Maskin's ideologies, because not many of them will understand it and know it. And so what I do is I buy his book on Amazon, and I ship it to the doctor's office. And I ask them to please read the book. And on my next appointment, I go in and I follow up, and I want to talk to them about the book and what their feelings are. And I will say that a lot of them are very open to it, and it's very eye opening for them. And a lot of them have come back to me and said, wow, I didn't understand it that way, and I didn't know it, and they would be willing to learn more about it. So that's what I do in my spare time. Is I go out and find these other doctors. All right, let's go on to some other questions. Um, let's talk about the steroid lavage. There's someone here, Ali Haddo. Patients have described the steroid lavage offered after probing. Would like some more information about that, about the cannula and how you.
Yeah, so the idea is that once the scar tissue is released with probing, again, the pressure is equilibrated on either side of the scar, lid tenderness goes away, but now we have a gland that has had meibum and associated debris and inflammation trapped behind that scar tissue. Now, some meibum will come out by virtue of just releasing the scar tissue, and the pressure the equilibration of pressure will bring some of that oil out. But left behind are inflammatory debris and so forth. So I gently emphasize gently express. But after that, I like going in with a little microtube and lavage or rinse out the interior of the gland. So that rinses out the material that had been trapped and still sitting there behind where the old scar tissue was, and leaves an anti-inflammatory coating. So I like to do that, and we get good results, and patients enjoy that. They like that results.
And Dr. Toyos had said in that video of that when you to probe or not to probe, that YouTube video, that when you probe, you actually push all of that down into the gland. What did he mean by that? What does that mean? Does he push the meibum or you
push the that doesn't make any sense at all. In fact, one of my earliest videos, I actually show how when I pass the probe into the orifice and into the gland, when the scar tissue is released, the oil is forced out of the gland because of the pressure that was elevated behind that scar tissue. So the pressures like to equilibrate, right? They like to equilibrate. So if you have high pressure behind the scar tissue and low pressure in front, you release the scar tissue and the oil comes right out. There's a video, it's out there on the internet. It shows the oil tracking along the probe. It's like the probe's a stent. And for the meibum, it just tracks right along the wire probe and out through the orifice. It's ridiculous to say probing pushes oil back into the gland. That's just ridiculous.
Okay. So one of my adversaries on Reddit had mentioned when I had posted our Q&A, and I welcome all of it. I welcome all of the pros and the cons of this. And said, well, you guys are just going to talk about probing because that's all Dr. Maskin does is probe. Now, I'll grant him some of that, but it's so important because it's so essential to restore the ductal integrity of the meibomian glands, right? So you just taught us all about that on this presentation, and we are talking a lot about MGD and probing and glands, but you also have done something for me because of my severe aqueous deficiency. So you restore the ductal integrity of my glands. The evaporativeness of my dry eye went away. The pain of my conjunctiva, because by the way, I had the AMT surgery, which I know we have to talk about more, but at this point in time, it's ran so late. We're running so late. Let's talk about the aqueous component, right? So when I first saw Dr. Maskin, I was severely dry. One of his comments was he puts this thing up my nose. He's like, wow, you're severely dry. We closed my puncta, but I was still struggling real bad. And I had said, what else can we do? So Dr. Maskin had come back. He said, listen, there's been some studies out there for PRP injections into the lacrimal glands. The research study, correct me if I'm wrong, was done on Sjogren's patients mostly. Right. And Dr. Maskin said, listen, we could try this, but, don't get your hopes up because it's only been researched and performed on Sjogren's patients. So we really don't know what the outcome is going to be on this, but let's give it a try and let's see how it comes out. So I wanted to just tell everybody about, he's not just a probing doctor. He has also researched, and he started to perform these on me. When I had my puncture closed, my Schirmer score went up to a 5 and a 6, left to right eye. And I started the PRP injections into my lacrimal gland. I fly down to Tampa, have my blood drawn, it's spun, it's whatever they do to it, and then he injects it with a nano needle into my lacrimal gland and my upper eyelids. And within 3 months' time, I was seeing results of 15 and 16 millimeter on my Schirmer score. So I responded tremendously, and it was a total game changer for me. So I want to share that, and I'd like to talk about that, Dr. Maskin, and your point of view on it.
Well, before we talk about that, if I may, the whole issue of probing, from my mammalian glands, and that's, it's a major part of what I talk about. There's the key, again, the key concept here is this. If you have appendicitis, you don't take out a gallbladder. You target your treatment for what's wrong. You do an appendectomy. If you've got MGD, that means you've got periductal fibrosis. You probe the gland, period. You have to target what's wrong. And that's how you get success in an efficient manner. So my patients do well rapidly. They do very well quickly, as opposed to requiring months and months and months and months of treatment and multiple cycles of treatments. Not necessary. So when someone asks about that, why you just do probing? Why is probing your major therapy for MGD? Is because of the periductal fibrosis, and we want to target what's wrong. The same way a surgeon takes out the appendix in the case of appendicitis and not a gallbladder. Very important concept. Another analogy I'll give you is this. Let's say you have a blocked intestine. Let's say you have an intestinal blockage. Okay, so for whatever reason, you have scar tissue wrapped around your intestine. So all you can do is eat soft food or liquid. Why not remove the scar tissue? Why not release the scar tissue? You can enjoy a cheeseburger again or a nice steak. Why live with that scar tissue? You want to go right to the problem, go right to the problem, the periductal fibrosis, release it, and restore your glands, restore your comfort, restore your life. On the matter of lacrimal gland injection for aqueous tear deficiency, we probably have maybe a dozen or so patients, maybe 15, even 20 by now. And we recently started looking at the data and analyzing the data. And Claire tells me that the data looks good, it's favorable, it's statistically significant, but we need to really get deeper into the data to analyze it, to be able to talk about it. Right now, I can just speak anecdotally. Obviously, you can speak anecdotally that we're seeing some, good results, but I really can't get into details. We don't have the details just yet. But I would just say for those patients that have, they've had their punctum closed, they still have aqueous tear deficiency, then it's something to consider. It's something to consider. And I would encourage people to look at the studies, and they can call us up for more information as we continue to analyze our data. And it's a possible intervention that could be of some help to patients.
And it's one of the only things that isn't unable to be fixed at this point, the way I see it, right? MGD is completely fixable by probing how you're treating it, but the aqueous tear deficiencies, because lacrimal glands do not reproduce, or the disconnect between the cornea to the brain, and that's a huge.
Some people looking at doing like salivary gland transplants and those kinds of things. So those are considerations as well. Again, that gets into more specifics, case by case specifics about whether a patient is a candidate for that or not. Um, but there's work being done in the area, but I would say that by and large, we're able to restore adequate moisture through the therapies we talked about.
All right, we kind of got off the questions again, so let me jump back on there. Con,
10 more minutes, okay?
I'm
10
sorry.
more, 10 more
Okay,
minutes?
all right, yeah, that's fine.
But 8 o'clock.
As much, wow, all right, as much as I can get from. I know we're going to do this again. So, Connie Galloway is a name I know. I've spoken with her over the years. Mucin layer. Is there any way to measure quality? Any treatments?
Well, patients with mucin deficiency typically have a history. There may be chemical injury, thermal injury, Stevens-Johnson, pemphigoid. I mean, there's typically a history there because the mucin comes from the goblet cells of the conjunctiva epithelium. Uh, so, the therapy itself, assuming you're not vitamin A deficient, the therapy itself is really specific to the history. Um, and the findings on examination. Um, and so, um, and what if you have, you see, if you have one of the, for example, if you have had a chemical injury, thermal injury, that can cause vascularization of the cornea. So that brings in that issue. You can be stem cell deficient of the cornea. So mucin deficiency usually is accompanied by a significant history, and that's really a specific case to evaluate and then make recommendations for.
All right. I being we only have a short amount of time left, I want to just touch on conjunctival chalasis and my own experience first, and then we'll go on to people have a couple questions. When I first saw Dr. Maskin and in the tests that he had Claire in his office performs the tests uh, with him, and they diagnosed me with ATD, real bad severe aqueous deficiency, and MGD, of course, and conjunctival chalasis, which you see CCH for short. And the fix that I had performed is Dr. Maskin performed AMT, amniotic membrane transplant surgery on me when he actually cuts out, I may mess this up, the bulba conjunctiva, the inner eyelids, and replaces that stretched skin. So what was happening with me was the skin would stretch on the inside of my eyelid, and every time I blinked, it would roll and get pleated, and it wouldn't clear my tears from the
That's,
outside to the inside.
that's the bulbar conjunctiva. Yeah.
Bulbar conjunctiva, right?
Yeah.
Again, the medical terms,
That's the conjunctiva wrapper that's covering the white of the eye.
right. All right. So mine wasn't clearing. It was pleated. It was wrinkled, and it was stretched. So that was causing a whole host of problems for me and pain and different things. I had a lot of comorbidities. And in the beginning, Dr. Maston said, "Look, we're going to put your eyes back together anatomically first and foremost, and these are all pieces of the puzzle that we have to attack one at a time, and it's going to take a little while. So be patient." And my patients have seen very good results. So my conjunctiva, I went in to the hospital in the morning, Tampa General, right up the street from Dr. Maskin's office.
It's Memorial Hospital.
Oh, sorry. Right. Memorial Hospital. They put me under, and Dr. Maskin performed the amniotic membrane transplant
For the chalasis.
for the chalasis. Can you explain quickly a few minutes about that? How it's done? What do you do? And
Well, yeah. So the most important thing is diagnosis. um, and again, that's where. So the most important time is in the exam room evaluating the patient to determine if the chalasis is number one is there, number two if it's symptomatic. So patients will sometimes say to me, "What grade of chalasis do I have?" And I say that's not important. What's important is if it's symptomatic to you or not. So in some patients, mild chalasis, patients more advanced chalasis may not cause any symptoms. So it's really patient specific. But once it's determined that the patient may have superior chalasis, which is more, the symptoms there are more friction, where the patient's upper lid is kind of grinding over the surface of the eye, and the friction creates inflammation and irritation, discomfort, as opposed to inferior chalasis and inferior temporal chalasis, where the patient often complains of heaviness and tired eyes. Maybe the moisture collects at the outer corner of the eye because the lower chalasis, inferior chalasis, channels the moisture, the tears to the outer corner rather than letting it flow across to the nasal, toward the nose, and into the punctum. So it's important to identify which or both chalasis problems the patient has. The procedure itself I like doing it under what's called LMA, which is laryngeal managed airway. It's a very easy procedure for the patient. They don't, they're basically, it's like a mild general anesthesia, and takes about an hour depends how much, if I do both upper and lower at the same time, it could be an hour and a half. And I essentially identify the tissue to be removed. I, again, excise the tissue. Patient doesn't feel anything, as I said. And then I reconstruct with the amniotic membrane. I tailor the membrane to fit in that area where I want to reconstruct. And I use a combination of adhesive and suture to secure it into place. And the patient leaves the operating room with a patch over the eye. And it takes 2 weeks. And in that 2-week period, the cells regenerate. They grow over the membrane and they heal it in. And it's rapid. The patient doesn't have to wear a patch during the day. They can wear glasses. They can, go about their business. The only thing I advise is to stay away from any particulate matter. But other than that, they take their steroid drops, their antibiotic drops, and then with 2 weeks, it's essentially all healed, and they benefit. They can tell a difference right away within a couple of days because of that removing of that heavy, um, that heavy, abnormal tissue. So very successful, and it's amazing because I mean, patients have come to me. Again, it's another example. Patients have come to me saying that others have told her that there's nothing wrong with her conjunctiva, where clearly she had symptomatic chalasis, and she was miserable. She was suicidal until after we fixed her chalasis. So even something like that could actually, make a difference in someone's life.
Right.
The recovery is easy, straightforward. I would say mild discomfort. Tylenol might be the only thing you need for discomfort or aching. It's pretty straightforward procedure. Most patients say, you didn't tell me it was so easy. That's the kind of typical thing I get.
Yeah, it was very simple. It was no pain for me even afterwards. You had prescribed some pain meds. I didn't even use them. It was a simple procedure. Uh, One of the people that I've spoken to had bad lagothomas from it. Right, their eyes were staying open. I had to look that up. Lagothomas. Don't ever try to spell it. So their eyes wouldn't close because their bulbar conjunctiva was actually stopping their eyes from closing.
Right. So this is interesting, and this is something we're looking at now, that we're seeing by managing the surface disease the way we talked about, releasing the scar tissue, get the glands functioning again, treating the comorbidities, we're seeing patients restore better blinking. And that's very important. A better quality of blink is very important.
Sorry, my iPad is telling me that we have to wrap this up.
Okay, I got you. One
Yeah.
last thing. I noticed one question. Um, the question was, what do I do if my glands are atrophic? Now, it's very important. My Bowman glands are atrophic. I urge you, get probed. Why? Because there are times where you don't see gland tissue in mammography, but you may have colonies of cells remaining. And then, as long as there's an orifice, probe the gland. And I published a paper on that. You can probe the meibomian glands as long as there's an orifice. Probe it. You can restore functioning to the cells that are remaining there that you cannot visualize on mammography. Don't give up. If there's an orifice, a gland orifice, make sure you probe it. This is an area, by the way, that we're actively studying and researching is how to regenerate glands in a macro fashion. For example, we know with our at a cellular level, we showed earlier tonight how at a cellular level, the probing leads to duct regeneration. Okay. We also didn't go over this, but in a retrospective study we published in 2018, we also see increased gland tissue after probing. But we want to jump on that. We want to take that and take it to the next level, and that's a part of our active research efforts here. Do not give up just because you don't see gland tissue on mammography. I have many patients with minimal to no gland tissue on mammography that again have done very well.
Excellent. All right. Yeah, my iPad had warned me that I'm low on battery. So crisis averted. I think I found a charger. Never thought this would go that long. I just want to put some a closing statement out there. The first thing I want to do is tell everyone that I started my own social media page on Facebook. Claire, can you post that, my page? And what I want to do with this is it's mostly going to be geared towards Dr. Maskin's ideology. You can join if you want to, if you want to learn more about what Dr. Maskin, how he treats this disease and what his thoughts and his findings are, his scientific approach to it. And we're going to post this recording on my Facebook page. And at first, it will be shared on other YouTube and things of that nature, but it's going to be here exclusively for a short period of time, because I do want to get people to come to my site, just to be able to discuss things with Dr. Maskin, because he'll be checking in on it. I want to try to get him out there, but he's so busy with his schedule that it's hard for him to talk to us, right, and to answer questions because he's so busy treating people. So he's going to be checking in on this site, and answering questions as well as myself. And then just a closing statement. I like to thank all of our fellow dry eye sufferers for all the interesting questions asked tonight, and would especially like to thank Dr. Maskin and his lovely research assistant Claire for dedicating their time and effort. She's behind the scenes out there. She does a lot of, I'm not sure what her title is. What is her title in your office? Research. What does she do?
Research assistant, personal assistant. She's terrific.
She's unbelievable. Knows more about this than anybody I've ever spoken to other than Dr. Maskin about this disease and helping us. And she does a lot of the testing in Dr. Maskin's office, which a lot of the patients, when we find our way into Dr. Maskin, a lot of us, it's our last chance at life. She's going to make it, and she makes it more pleasant to be tested.
Let me just, if I could intersect one thing, Matt.
Yeah, please.
I just want to mention this. I encourage everyone here that's listening or viewing this to really to understand these concepts. I frequently get patients, probably every 2 to 3 weeks, who are suicidal. They're suicidal, and with, I'm going to say, concepts, let's put it this way, they don't have my concepts. They don't have the foundational concepts that I use to achieve success. And they come in, and there's so much time I spend teaching them how we're going to make things better. It's so important to understand the concepts we've talked about today, so that you can, again, achieve the comfort, you can receive the care you need promptly, efficiently, and I think, again, that it'll only help you, because patients come and they learn so much when they come here. They had no clue, no understanding of the complexity of their condition and the abnormalities that we find, and it's a lot. It's a lot for patients because they had no idea. So if you understand the concepts, then you're that farther ahead. You're that farther ahead when you come here, And so I encourage, if you do decide, or at some point, if you decide to come here, or even if not, if you embrace the concepts that I'm sharing with you that are in my book, then you're miles ahead, and it'll just make it'll just make things a lot easier for you and your family and loved ones as you get your life restored. Keep your hope. You know, again, I see this all the time, but every 2 3 weeks, a suicidal patient comes here, and we turn them around. So, um, don't give up. Keep your hope, and learn it maybe a different way than you've been taught about how to manage and diagnose your dry eye. Thank you, man.
Amen. I also want to put my email out there. I was going to get a separate email, but I just didn't have the time. So I want to put my email, my business email. I don't know, Claire, did we have any way of posting that up there? I'll just verbally, it's MATT at mc-electric.com. So if anyone wants to get in touch with me, I saw in the comments that some people want to talk to me. I am always available to talk to someone who's suffering. I want to get that out before I get emotional, because I do.
And
Uh,
Matt, we all want to thank you. We want to thank you for your heartfelt desire to change the world in the way you do. And every patient, every person is a life, and every life you save and restore comfort to is the whole world.
yeah, that's my email, Claire. Thank you. I also give
So,
out my cell phone. I've posted it on the dry eye sites as well. And I talk to people all times, day and night, other people from other countries. I give them my experience and what I know. So I'd like to put that out there as well. Uh, my cell phone, 516-578-8231. A lot of people have said on here they want to talk to me. They're more than welcome to hit me up. What else is there? Anything else? I want to thank Dr. Maskin for helping us. I've been after him for a little bit to do this, and we've talked about it, and I just got to thank him so much, because I know his schedule is insane, with his family and with his business and with his practice, and I'm trying to help people. A lot of people out there don't know Dr. Maskin, so there's people on the site that say horrible things about him, and it really just gets me to my core, and I go into attack mode, because this guy saved my life. Uh,
we're good.
yeah, we're good. So anyway, in closing, go to my site, email me, text me, call me. Dr. Maskin, again, a big thank you. I love you. What you do is amazing, and what you do for your sufferers and for your patients is just unbelievable. Best guy I ever met, a true humanist. And he's in it to help people. And he's encouraged me to become a patient advocate as well. And he's just always trying and looking to help people and save people. And a lot of people don't know that about him, but they need to. I wanted to get him out there because he's such a handsome man. He would present so well. And I wanted to put him out there because you see the other mainstream doctors that are out there talking about this and promoting all of these gizmos and gimmicks, and it burns me. But that'll be another topic that I'd love to share with everybody, my opinion of the pharmaceutical and the dry eye cartel, as I call it. But that's for another day. So thank you very much, Dr. Maskin. Thank you, Claire. Everybody in his office are just tremendous human beings. Love them all.
Thank you, Matt.
All right, bud. All right.
Good night, everybody.
Good night. Thank you.